Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Hello and welcome back to the Sit and Stay podcast, the show where mental health providers learn to keep their practice healthy alongside their patients. Brought to you by RipsyTech, an electronic health record company dedicated to addressing the mental health crisis in the United States. I am RipsyTech product manager Parker Anderson, and as always, I am joined by the founder and CEO of RipsyTech, the sanguine Tom Tarshis. Hi, Tom.
Hey, Parker. I know the roots of sanguine saying is blood, but actually don't.
That is the roots. It's like optimistic even in rough times, I think is the official definition.
I like that.
Yeah. Well, so today, for today's episode, we are going to talk about an article that was published on January 15th, 2025 by Ellen Berry at the New York Times. It was titled, "Online Therapy Boom Has Mainly Benefited Privileged Groups, Studies Find." So in this article, Berry explains how the boom in online therapy during the pandemic has largely benefited more privileged groups while leaving behind the individuals and communities who may need mental health support the most. So to dive into this topic, I wanted to, just first ask you, Tom, like from your perspective as a practice owner, what have you observed about the rise of teletherapy?
Yeah, and we can do a little historical perspective. So the first time I ever did a video session was like the year 2001, and I was in Arizona, and we were in the county hospital, and we needed to do an evaluation for safety for someone in a different emergency room. And so I was actually there with I was a resident, and I was there with a medical student, and they had this, expensive sort of camera system where we could see into the other clinic that this patient was. And so that was a long time ago. And that was the first use that I saw of this video. And it was at that time, I thought, this is great that, this rural area that doesn't have a lot of services, we're able to like video in there and do an evaluation on a psychiatric patient. And I think that was the first time as a clinician, when we all heard about this, we thought, oh, right, this is going to be great for rural areas or, places where people can't get into a clinic. And so that was, an exciting thing I even remember from 25 years ago. And then, with the, better technology and faster internet, we did start, seeing people initially using telehealth to begin to do psychotherapy sessions, but it was not something that was covered by insurance at the beginning. Other than in California, we had Medi-Cal, which would actually allow phone visits because they recognize that a lot of their clients don't have transportation or ways to get to appointments. So they were the one insurance company that let you actually bill for phone calls. But there were problems. Yeah, I think as we've talked about before, there were initial problems with insurances not paying for telehealth services, and it not being fully adopted by the world because a lot of people didn't have easy access to televideo platforms like Zoom or Google Meet. But then the pandemic sort of fixed all of that. So once the pandemic happened and this was the new norm, all the potential positives of this is a great way to provide services for those who otherwise couldn't get an appointment or make it to a clinic, that all was on the top of everyone's mind. And could this now be the revolution to deliver mental health services to places that couldn't get it before? And I think, years have passed now. I think having this article come out, and we'll talk more about it, but that was for those of us who are interested in public health, it was very exciting potentially to have this tool available to help serve these populations in need, which we know are struggle both with physical and mental health resources.
So, as my follow-up question, I would want to ask, does your experience align with the finding from the study that, or with the article's findings talking about the different studies that kind of show that a majority of telehealth clients tend to be more higher income or more educated backgrounds?
Yeah, right. And so I think what happened was that it is true that it did potentially open the door for more clinicians to provide services to people who couldn't otherwise get them. But the reality is it also opened the door to a lot of new behavioral health providing platforms that could pay people better, so that what ultimately would happen is if you were one of the few clinicians that lived in a more rural area or even in a very urban area, working with underserved clients, though, who, had problems getting to the clinic or that access, the reality is the market and demand for mental health clinicians shot up. So people who otherwise might have been able to work with the underserved groups, or maybe that was their passion at some point, when you're being offered significantly more money in a different job, people will tend to gravitate towards higher paying positions, no matter how dedicated you are to a certain population. So ultimately what happened was we took away providers in the communities that could potentially be working with these patients who can now work from home for other platforms. And what's happened there, though, is the people who can really access telehealth services are people who can pay cash or who can use their insurance. So you're really looking at middle class, upper middle class, affluent populations that even have this level of insurance and privilege. And that is what the article talks about, and that is what has happened.
Yeah, that's a really interesting perspective that you brought up, because I've been doing a lot of some of my own digging on advice on how to best set up a practice. I mean, that's what our entire podcast is about. But I've even come across guides online that are all about helping a provider figure out how to start taking private pay clients, start making more money from not taking insurance payments, and what's the strategy around how to do that. And that to me is really interesting with everything that you're saying, because it does, doing something like that is really narrowing the type of patient that you are allowing yourself to be able to see, and you are one less provider that somebody who has more barriers to getting treatment can access to see for an appointment. So given that the article is highlighting that it was seen as a way to expand access to underserved or remote populations, like you brought up. You just brought up one really good perspective. Do you have any other thoughts on why you think it hasn't lived up to the promise?
Yeah, and just to throw in a little more like real world data. So we do some work for a community-based organization in Oakland, and that involves going into schools to try to work with kids in school settings, which is a great place to connect with kids. And it is definitely has been the experience that, previously there's a high no-show rate for people for low income or on Medi-Cal, and for various reasons you can imagine that just making it to appointments is a hardship. So one thing that has been great about telehealth, and the fact that almost everyone has a smartphone now, is that for these patients that used to be a no-show or couldn't get somewhere, we have really been able to quickly send a text message with a link, especially for teenagers or for the parents of the kids, like, hey, you have an appointment, click this link so we can make that appointment happen. And that's a case of where having that telehealth and everyone having a smartphone now has really helped to make sure that a lot of the population is able to get their appointments. So there is, with wide adoption, this technology piece could actually, it certainly could do what it was hopeful to do, which is make it easier for people to have these appointments and get the care that they need. So this isn't really a failure of, the technology piece. It comes more down to society, capitalism, recruiting piece that, if you're going to be able to do the same sort of provide the same service and make a lot more income as a therapist or a clinician, I think that's a justifiable reason to like say, hey, I don't want to work for half as much money when I could do, work less and have this other position. And so I think the challenge comes with how do we do a better job of getting providers to be willing to still work with this population, knowing that it's easier than ever to actually connect from a technology standpoint and a clinician standpoint. But how do we solve the more competitive job market and better offers that are around for mental health clinicians?
Interesting. Well, so I guess what I'm wondering is like, do you think there are any reasons why it might be more difficult for somebody living in a more remote community to access their telehealth appointment? Like, I don't know, like high speed internet access or maybe digital literacy could be a factor. I'm also considering like, if you're doing a telehealth appointment, and most people who do their telehealth appointments are doing them at home, it's something that doing that requires that you are, comfortable doing that, doing your telehealth appointment at home with the living situation that you have. So those are some factors that kind of came up for me as I was considering this question.
Yeah, and right, and it's if you have it's a fair point, and I think that in more rural communities or communities without as much resources, there can tend to be a technology gap with respect to high-speed internet at home or having computers and some of the other technology advances. All that being said, though, smartphones and cell service is now pretty ubiquitous in all parts of the country.
Right.
So having a high-speed internet connection at home, on some level, it doesn't matter if you've got your cell phone, which the technology has gotten better for streaming video, that you can actually do these visits just with the cell plan and someone's smartphone, which I think almost every house has. So then if people have that, what are the other barriers that could be associated with, picking up your phone and doing the call? And there could be other underlying attitudes around, is the call being recorded? What's being said? Is that still a little bit scary to do a video session and not in person? That can all definitely play into it. But I do think that some of the, given where cell services and cell phones are at, I feel like the technology barriers shouldn't be as big as they were a few years ago.
Yeah, I mean,
I don't
especially with
the
pandemic and a lot of people having to switch to an online way of, working or going to school. So, yeah, I mean, that makes sense. yeah, it's making me realize that this is, not as clear cut of an issue as it might seem on the surface. Okay, you touched on this. You've pretty much already touched on this, but I'm wondering if you have any other thoughts on how mental health professionals and telehealth platforms might be able to address the barriers faced by lower income families or rural communities, individuals with serious mental health conditions, et cetera, et cetera.
Yeah, right. There is still the challenge is for finding the group of mental health clinicians that are passionate about work in underserved settings and feel comfortable with you know at times extra socioeconomic and other factors that can make treatment more difficult. So you've got this segment of people that are passionate about helping those from underserved communities, and then we want to find a way to make sure that they're properly compensated and it's very easy to connect with the community. So I don't it's hard to say that I have all the answers to this
Right.
piece.
Of course.
There are a lot of clinicians, I think, who say, okay, I'm going to do 4 days a week with this one group and then do a day a week working with underserved populations. But it's not super easy to have that 1 day a week, to make that a reality where you have this 1 day a week that you're working with an underserved group. Are you going to, we're actually dealing with a little bit of this now where we're trying to be active with a Medi-Cal program in Southern California only, but that we're going to use telehealth to be able to provide services there. But it's not as easy as just saying, hey, we want to do this. There's, I've already been emailing lots of different people and how do we get set up? And even though we're credentialed with the parent insurance company that monitors this Medi-Cal program, they're of course in different divisions. So what seemed like maybe it was a very easy process to make happen is way more complicated. And this is for, 2 decades of experience in dealing with issues like these. So if you've got the idea of figuring out a way to make a very easy path for people who are like, hey, I have 4 hours a week, or I can do 1 day a week, or I can even one patient a week that I'm willing to see in an underserved setting. It is not, there's no easy path for that person to make that happen.
Right.
And that, I think, is the biggest barrier.
You were very good at answering my future questions ahead of time. Well, so something I want to talk about from the article, I believe it's the second to last paragraph, I think really stood out. I'll just read it verbatim. It says, during the years of the pandemic, the use of mental health services by Black children and adolescents decreased, falling to 4% in 2021 from 9.2% in 2019. In the same period, the use of mental health care among white children rose to 18.4% from 15.1%, the team found in another study. So, given those statistics, do you have any thoughts on, are there any systemic changes, specific strategies that can help reverse this trend? And this is to my point about, maybe you already answered this, but framing it specifically like that. Any other thoughts?
Yeah, and then I would hope that, people that have fewer resources and then affected by the pandemic, you're trying to sort of just survive, pay rent, get food on the table. And those adults in those situations, and where there's disproportionately higher single caregiver homes, they're not there to make sure the computer or phone is turned on for the appointment with the clinician. Right? It's just not going to be a reality where they're going to be the same sort of level of availability and support to make sure that the technology is ready for the visit. And that is what has happened, right? That the pandemic was hardest on low income families and people who had to work in-person jobs. And I think that that's the not having those caregivers at home to facilitate, it's no longer needed a ride to the clinic, but even to just facilitate having the technology ready for the appointment, it is the reason for that lower utilization rate. Whereas among more privileged groups, they're going to be more likely to have a caregiver there to make sure technology is turned on and they can show up to the appointment, and are more likely to even reach out and get those appointments scheduled. So, it's almost this, it's an extra step of care needed to, it's this idea of, we used to need to get taxi vouchers to bring people into the county clinic in Arizona because there was no other way that they get to their appointments. And, what strategy can we use to really make sure that the kids are going to have the technology ready and available, and that we encourage families to reach out to get those services. And it's just disheartening, right, to see that this has happened. And unfortunately, I think it's sort of a systems, big systems approaches that are needed, or some innovative solutions to reverse this trend in access for the telehealth services.
So looking forward, so I'm looking at a paragraph from the article I think is also pretty interesting. Specifically, there's not necessarily the first sentence of this paragraph, but I'll just read the whole paragraph. It says, if you can't afford it, no matter the modality, you just can't afford it, Dr. Wright said, and I believe that is C. Vale Wright. And it may be, she added, that weekly therapy sessions are simply not scalable to a broad population, and the field should explore light touch alternatives like single session interventions in digital therapeutics. So, I get looking forward, how do you feel about teletherapy being adapted or restructured to become more equitable? Are there any alternative models that we should be considering?
Yeah, I mean, there's a lot of good work on this, like in a lot of very strained resource settings throughout the world, and they talk about this. Yeah, if it's a single session, can you do stuff in a single session that can be very helpful? Can you get paraprofessionals or people in the community that are respected and train them, and they sort of act as a mental health professional without having the specific training, but can be available? And the digital therapeutics, I'm not sure. There's a big question mark on the digital therapeutics, which is like, is there an app that can really help you a lot with your anxiety or your depression?
Right.
There are studies on different apps that come out with good findings. However, this is like not generalizable to a lot of other populations, and until we see some profound study that really shows this smartphone app really helped with trauma or anxiety or depression, like I'm skeptical of that piece.
Yeah, that's interesting that you bring that up, because I it's a concept that's existed, I think, for so long that we've had the technology to do, or we have the technology to fulfill that concept, and many people have taken a shot at it, but it doesn't seem like we're finding that there is like a clear market for this, because there is no clear front runner that everybody's talking about saying, this app, you got to download it. It, really helped my mental health. And I think the reality is that there's no one size fits all approach to your mental health. Everybody needs something slightly different. And I going to therapy is probably one of the most effective things that you can do. And, I'm not sure I've ever encountered an app that was a suitable replacement for that.
Yeah, and we do. I mean, there are some good meditation apps that
Absolutely.
have stuck, and there are some good mindfulness apps that have sort of stuck and that people use. And so there's yoga apps, right? There's some exercise ones that have made it and have been adopted by millions of others. But yeah, we don't have that cure your anxiety, one that has really made huge differences. Maybe that will happen in the future. I don't know. Can there be something with AI that helps with an app? And still don't know. We're exploring things, but nothing's been super exciting or groundbreaking yet. So it is this, patient engagement is the most important part of any therapeutic relationship. So
100%.
And I don't think an app or even, the idea would be like, is there a way to quickly build that sort of relationship and then use that to leverage a less frequent or easier to obtain sort of treatment course? And, the easiest way to build a really good rapport with someone, and in underserved communities that are still more skeptical of mental health treatment, it's to be in person or go to their house or really make a connection.
Right.
And that's a challenge that I'm not sure we know how to solve yet.
Yeah. I mean, some words that you said that stood out to me, like rapport and connection, those aren't necessarily something that you can tangibly produce in a piece of technology compared to another human being.
Right.
Well, before we move on, any final thoughts?
Yeah, I mean, I think the teletherapy has been helpful for the providers that have been present with underserved communities or rural agencies for some time. So I think it has been a good tool for use among the people who are already working with these entities. The challenge is we've lost some of those people that work with the entities, and is there a way to sort of for someone to come in and really sync up complex, government insurance structures and clinics and and do it in a clean, easy way to boost care. And I think it's especially challenging in California, where each of the different counties sort of does its own thing. But there are other states where, things are more centralized, and it could be more interesting to try some experiments there. So I'm always hopeful about technology. I think I'm
sanguine.
Yeah, optimistic about it, and would like to see it actually lead to better utilization of mental health resources and better mental health outcomes for these communities. I understand why it's actually hurting the communities at this time, and there's no blame on any mental health clinician who wants to earn a higher salary in order to live and support their family.
Right.
So, it is multi-systemic, lots of factors coming into play that are part of the discussion and why this has happened. So,
well said. And I think, that's, and that right now, like this podcast episode, I mean, I think it's really, it's a snapshot of what things look like right now. And, things are always changing all the time. So, it'd be really interesting to see where we're at with this in a few years.
Yeah, agreed.
Well,
and then, I can pull a mental health business moment of the week that also
feels relevant to this.
Is relevant. Yeah, and right now we've mentioned that I got licensed in Hawaii, and we're looking to get connected in Hawaii, and I recently reached out to one of the insurers to see about getting the Hawaii contract. And right now it's at the point where, so I'm licensed in Hawaii, we can do teletherapy visits, but an insurer, when I sent in the application, wrote back, do you have an actual Hawaii address where you're going to be, providing services? So I said, hopefully that will be the case in the future, but for right now, located in California, and we'll provide the services via telehealth. Mm-hmm. And I don't have an answer back yet about whether they'll even explore contracting with our nonprofit if we don't have a physical location in Hawaii.
Interesting.
And so, yeah, it feels bizarre to me with the need for child psychiatry, the advent of telehealth services. The state of Hawaii will recognize us, and we'll have an address in Hawaii for communication, but an insurance company saying they won't credential us or let us provide services unless we have a physical clinic is just a barrier to care and not logical.
So to try and translate this scenario to, a more typical situation, because I assume one of the insurance companies that you were trying to develop a contract with in the state of Hawaii is specific to the state of Hawaii. Is that correct?
Well, so.
So my point is, or I guess my question that I have is, say you're in network with a state that, in network with an insurance that has, offers therapy plans in the state of California and Oregon, and say you're you get a new license in Oregon, and it's, one of the top, 5 insurance companies that everybody knows about. So when you become licensed to see people in the state of Oregon, does your in-network contract that you created with that insurance company in the state of California, does the same thing apply in the state of Oregon? And so then, if the answer is yes, then as you mentioned, if it's a barrier to seeing patients in a state like Hawaii, if the insurance that is, most popular in Hawaii, that, you need to get an in-network contract with them because, they're not available in the state of California, that is kind of creating this barrier. If they're requiring a physical address that you might not encounter if you were to be, making a plan to, go to some other state with, with a well-known insurance company that's not, specific to any one place. Sorry, that was a mouthful. So it was hard to elaborate.
Yeah, well, so there are insurance companies that offer sort of, you can contract with them nationally.
Gotcha.
So you could get a national Optum contract or a national Blue Cross contract. It's harder to negotiate some of those at times. In general, they don't pay as well as individual state contracts. But if we had a Blue Cross, an Anthem contract, a national Anthem contract that paid, here's the rates you get regardless of where you see the patient, then I think that wouldn't be an issue. We would be, as long as we were licensed and had the malpractice coverage, we can see the patients in the states that we're licensed in. But it's not, for smaller, that's sort of an undertaking for massive mental health companies to have that presence and to actually try to get a federal level contract. Sometimes it's very big hospital or other health systems that goes to, not so much smaller or even pretty big groups, in a location. But I would hope that I'm curious to see what ultimately happens, because it's not logical. Is it just a roadblock that's intentional by insurance companies to avoid getting someone else available to see patients? Because if there's not someone to see your patients, you're sort of off the hook for paying for it, sort of situation. So that's the cynical point of view, is like, let's make it as hard as possible. Or is it just sort of a bureaucratic, they haven't caught up with the times, or maybe it's just an outdated error that you don't actually need to have a physical location in the state. But
interesting. Well, keep us posted. Okay.
All right.
Yeah. Wow. All right. Well, thank you for tuning in to this week's episode of the Sit and Stay podcast, brought to you by RipsyTech. If you have any questions or you're interested in being a guest on the show, send us an email at sitandstay@ripsytech.com. All right, Tom, I'll see you next time.
Thanks, Parker. Have a good one.
You too. Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at ripsytech.com.